First, we are going to perform the drop arm test. The examiner is going to passively abduct the subject's involved arm to 90 degrees and then instruct the subject to slowly lower the arm to the side.
Please lower your arm to your side.
The positive findings to this test are the subject is unable to slowly return the arm to the side and/or has significant pain when attempting to perform the task. This is indicative of a rotator cuff pathology.
Next, we're going to do the crossover impingement test. With the subject's trunk stabilized, the examiner passively and maximally horizontally adducts the test shoulder. Positive findings include superior shoulder pain, which is indicative of an acromioclavicular joint pathology. Anterior shoulder pain is indicative of subscapularis supraspinatus and/or biceps longhead pathology. Posterior shoulder pain is indicative of infraspinatus, teres minor, or posterior capsule pathology.
This is the posterior impingement test. The subject lies supine on a table with the test shoulder placed in 90 to 100 degrees of abduction and 10 to 15 degrees of extension. The test elbow is flexed to 90 degrees. The examiner sits or stands. The examiner's distal hand grasps the subject's wrist and hand, and the proximal hand grasps the subject's elbow. The examiner slowly rotates the subject's shoulders into maximal external rotation. The positive finding is reproduction of the subject's pain in the posterior aspect of the shoulder, which is indicative of a rotator cuff and/or a posterior labral pathology.
Next is the apprehension test, anterior. The subject lies supine on the table with the subject's involved shoulder in 90 degrees of abduction and the elbow in 90 degrees of flexion. The examiner slowly externally rotates the shoulder. A positive finding for this test can be interpreted if the subject looks apprehensive or expresses feeling of apprehension towards further movement in the externally rotated direction. This test is used to mimic the positioning and movement of an anterior dislocation of the glenohumeral joint, thus recreating a subject's episode of instability. Next, we're going to do the apprehension test, posterior. The subject lies supine on a table. The examiner places the subject's involved shoulder in a position of 90 degrees of flexion and internal rotation while applying a posterior force through the long axis of the humerus. A positive finding for this test can be interpreted if the subject looks apprehensive or expresses feelings of apprehension toward further movement in the posterior direction. This test is used to mimic the position and movement of posterior dislocation of the glenohumeral joint, thus creating a subject's episode of instability.
Next, we will perform the sulcus sign. The subject sits with the forearms and hands resting in the lap. The examiner stands with the proximal hand grasping the subject's scapula superiorly and the distal hands grasping the subject's elbow. With the scapula stabilized, the examiner applies an inferior distal distraction force with the distal hand. A positive finding is excessive inferior humeral height translation with a visible and/or palpable step-off, or sulcus deformity immediately inferior to the acromion laterally is indicative of inferior and/or multidirectional instability.
The Job relocation test is where the subject lies supine with the test shoulder in 90 degrees of abduction and full external rotation. The examiner stands with the distal hand grasping the subject's wrist and hand. The examiner's proximal hand is placed over the subject's humeral head anteriorly. The examiner applies a posterior force to the humeral head while the examiner externally rotates the subject's humerus. A positive finding is a reduction of pain and apprehension, and commonly an increase in shoulder external rotation are indicative of anterior instability.
Next, we are going to do the surprise test, an active release test. The subject lies supine with the test shoulder in 90 degrees of abduction and full external rotation. The examiner stands with the distal hand grasping the subject's wrist and hand. The examiner's proximal hand is placed over the subject's humeral head anteriorly. The examiner applies a posterior force to the humeral head while externally rotating the subject's humerus. Then the examiner quickly removes the proximal head from the humeral head. Positive finding would be a sudden return of symptoms that are elicited from the apprehension test is indicative of anterior instability. Next, we are going to do the crank test. With the subject standing, the examiner places the distal hand on the subject's elbow and the proximal hand on the subject's proximal humerus, and then passively elevates the subject's shoulder to 160 degrees in the scapular plane. With the distal hand, the examiner applies a load along the long axis of the humerus, while the proximal hand externally and internally rotates the humerus. Positive finding would be pain and/or clicking are indicative of a glenoid labral pathology.
The next test is the O'Brien test, which is active compression. The subject sits or stands with test shoulder in 90 degrees of forward flexion, 30 to 45 degrees of horizontal adduction, and maximal internal rotation. The examiner stands with one hand grasping the subject's test wrist. The subject horizontally adducts and flexes the test shoulder against the examiner's manual resistance. The test is then repeated with the subject's arm in an externally rotated position. Pain and/or popping that is present in the internally rotated position but absent in the externally rotated position is indicative of a slap lesion.
This is the Adson's maneuver. The subject sits or stands, and the examiner stands with fingers over the radial artery distally. The examiner externally rotates and extends the subject's test arm while palpating the radial pulse. The subject then extends and rotates the neck towards the test arm and takes a deep breath. A positive finding for this test is a diminished or absent radial pulse, which is indicative of thoracic outlet syndrome, secondary to compression of the subclavian artery by the scalene muscles.
Next, we're going to do the jerk test, posterior stress. The subject is seated. The examiner stands behind and to the side of the subject, with one hand stabilizing the subject's scapula and the other hand supporting the shoulder, an internal rotation in 90 degrees of flexion, and the elbow in position of 90 degrees of flexion. The examiner passively moved the subject's arm into horizontal adduction while also placing an axial load on the humerus. A positive finding would be the posterior is instability and suspected if the subject experiences a painful or non-painful clunk.